and welcome to NSG 323, Study Session 2, Abnormalities of Early Pregnancy. Introduction. A lot of women have experienced the issue of miscarriage or abortion one time or the other in their life. Though the issue of miscarriage is an unfortunate incident which at times happened naturally, but some of them are also caused by women overstressing themselves or by being abused either physically or psychologically by a second party. So therefore, in this study session, you will learn about the definition of miscarriage or abortion, the factors that cause it, the different types of miscarriage and abortion, the necessary investigations to confirm the condition of miscarriage or abortion, and finally, how to prevent or manage the issue of miscarriage and abortion. Learning outcomes. At the end of the study session, you should be able to define miscarriage and abortion, enumerate the causes of miscarriage and abortion, describe the types of miscarriage or abortion, list the necessary investigations to confirm the condition of miscarriage, discuss the prevention and management of miscarriage or abortion. Definition of abortion. Abortion or miscarriage is defined as the expulsion or extraction from its mother of a fetus or embryo weighing less than 500 grams or 24 completed weeks of gestation. Loss of pregnancy after 24 weeks is considered preterm delivery. Abortion can also be simply defined as the deliberate termination of a pregnancy, usually before the embryo or fetus is capable of independent life. In medical context, this is called an induced abortion and is distinguished from a spontaneous abortion, miscarriage, or stillbirth. Incidence. About 15 to 20% of all pregnancies end in spontaneous abortion, or 30% if all women who had a positive serum HCG are included. Majority prior to 13 weeks gestation, 1 or 2% occur 13 to 24 weeks. Causes of miscarriage or abortion. In most cases, there is no definite cause. A miscarriage may be spontaneous or induced. A spontaneous miscarriage can be due to genetic abnormalities. Embryos with chromosomal defects are seen in about 50% early abortions. Chromosomal defects may also be present in the placenta. For example, iridocephalus mole or molar pregnancy, causing death of the fetus. Faults in the maternal environment. Infections by Toxoplasma common, syphilis, Listeria monocytogenes, hormonal deficiencies, as in progesterone deficiency, in corpus luteum defect, or in hyperthyroidism or hypothyroidism, incarnate uterus, septate uterus, etc., cervical incompetence, RHV pregnancy, ABO incompatibility, some maternal diseases which cause high fever, uterine fibroid causing improper implantation of the placenta, physical trauma, e.g., a blow on the abdomen or that's caused by a fall, surgical trauma due to hernia operation, congenital malformations of the uterus like hypoplastic uterus, unicornuate. Types of abortion. Abortions can occur in two ways, which are death of the embryo, abnormal uterine activity. Death of the embryo. Death of the embryo or the fetus can be the first event to occur, followed by its expulsion from the uterus, This is usually seen in very early pregnancies. Abnormal uterine activity. In this type of abortions, the main event is abnormal uterine activity, causing the uterus to expel a healthy fetus. This is usually a feature of abortions in the second trimesters after 13 completed weeks of pregnancy. Risk factors. Pregnancies involving more than one fetus are considered at increased risk, and apart from this, there are lots of other risk factors of abortion, and among them are intercurrent diseases. Several intercurrent diseases in pregnancy can potentially increase the risk of miscarriage, including diabetes mellitus. The risk of miscarriage is increased in women with poorly controlled insulin-dependent diabetes mellitus. This 1998 prospective study found that the risk increased by 3.1% over the background risk of about 16% for each standard deviation in glycosylated hemoglobin above the normal range. The risk was not found to be significantly increased in women with good glycemic control in early pregnancy. Polycystic ovary syndrome, which may increase the risk of miscarriage. Hypothyroidism. Severe cases of hypothyroidism increase the risk of miscarriage. Vertical transmitted infections. Certain vertical transmitted infections, such as rubella and chlamydia, increase the risk. Autoimmune disease. Some research suggests autoimmunity as a possible cause of recurrent or late-term miscarriages. Autoimmune disease occurs when the body's own immune system acts against itself. Therefore, in the case of an autoimmune-induced miscarriages, the woman's body attacks the growing fetus or prevents normal pregnancy progression. Further research also has suggested that autoimmune disease may cause genetic abnormalities in embryos, which in turn may lead to miscarriage. Smoking. Tobacco, cigarette smokers, as shown in Figure 2, have an increased risk of miscarriage. An increase in the rate also is associated with the father being a cigarette smoker. The husband study observed a 4% increased risk for husbands who smoke fewer than 20 cigarettes per day and an 81% increased risk for husbands who smokes 20 or more cigarettes per day. Smoking. Advanced maternal age. The age of the mother is a significant risk factor. Miscarriage rates increase steadily with age, with more substantial increases after age 35. Exercise. A study of more than 92,000 pregnant women found that most types of exercise, with the exception of swimming, correlated with a higher risk of miscarrying prior to 18 weeks. Other factors. Sexual intercourse during the first trimester has often been said or assumed by doctors to be a cause of miscarriage. However, the association has never been proved or disproved. Musgrove, 2012. Physical trauma and exposure to environmental toxins. Physical trauma, like being physically abused, for instance, beating, assault, etc., and industrial waste in the environment, can cause miscarriage. Antidepressants, especially paroxetine and venlafaxine, can lead to a miscarriage. Signs and symptoms of abortion or miscarriage. Spontaneous abortion progresses through a number of stages with clinical symptoms of vaginal bleeding and lower abdominal pain. The chief symptoms of abortion, as shown in the picture, are pain and bleeding. Whether pain occurs first or bleeding would depend on whether the abortion is due to death of the fetus or abnormal uterine activity. Classification: types of abortion or miscarriage. Threatened miscarriage: the presence of bleeding from the uterus in an ongoing early pregnancy is called threatened miscarriage. Uterine size is normally consistent with gestational age. Cervical or hairs closed. Minimal or absence of lower abdominal pain. Some women presenting with threatened miscarriage carry the pregnancy to term. Inevitable or incomplete miscarriage. In inevitable miscarriage, there is increasing abdominal pain associated with heavier bleeding. Cervix opens and eventually products of conception are expelled. If some of the products of conception are retained, the miscarriage remains incomplete. Complete miscarriage. An incomplete miscarriage may eventually progress to complete. The abdominal pain subsides and involution of the uterus takes place. Miscarriage with infection. During a miscarriage or after therapeutic termination of pregnancy, infection may be introduced into the uterine cavity. The clinical findings may be similar to that of incomplete miscarriage, with uterine and adnexia tenderness, purulent vaginal loss, pyrexia, in some cases, overwhelming sepsis, and endotoxic shock with profound and sometimes fatal hypotension. Other manifestations include renal failure, intravascular coagulopathy, and multiple petechial hemorrhages. Organisms that commonly invade the uterine cavity are Escherichia coli, Streptococcus fessalis, Streptococcus aureus, and Aedes Klebsiella, and Clostridium rauchi and C. perfringens. Diagnosis. Initial clinical assessment involves determining the hemodynamic status and general condition for evidence of blood loss. Distension of the cervical canal by product of conception in an incomplete miscarriage may cause profound vaginal response, leading to hypotension and bradycardia, cervical shock, where hemodynamic compromise is present. The key differential diagnosis is ruptured ectopic pregnancy. Management of abortion. The management of abortion include treatment options, surgical evacuation. Treatment options. For women with threatened miscarriage, there is no specific treatment except reassurance that once fetal viability is confirmed, the prognosis of ongoing pregnancy is usually good. Where complete miscarriage has occurred, no further treatment is indicated. The next line of action is appropriate resuscitation and replacement of blood if indicated. Surgical evacuation. Surgical uterine evacuation of retained products involves the removal of tissue by suction curettage of the uterine cavity under general or local anesthesia. This has been standard treatment for all women with miscarriage on the assumption that retained tissue increases the risk of infection. Clinical indication for surgical uterine evacuation includes persistent excessive bleeding, hemodynamic instability, evidence of infected retained product, suspected trophoblastic disease. Where infection is suspected, antibiotic treatment should be given for 12 to 24 hours before surgery. Perioperative treatment with prostaglandins makes it easier to dilate the cervix and reduce the risk of bleeding and cervical or uterine trauma. Management of miscarriage. Expectant management of miscarriage. When there is no infection or heavy bleeding, the natural history of most cases of miscarriage is spontaneous passage of products of conception. Waiting for this to happen is an effective and alternative to surgery for women. Complete resolution may take several weeks. Expectant management is more likely to be successful in incomplete miscarriage, 80 to 100%, than missed miscarriage, 14 to 47%. Anti-D immunoglobulin. Rhesus negative women who are non-sensitized should receive anti-D immunoglobulin following any bleeding in pregnancy after 12 weeks of gestation or after medical or surgical evacuation of the uterus. This should be stated in patient's documents. Medical management. Various treatments using prostaglandins with or without antiprogesterone have been described effective. The success rate of medical management depends on the type of miscarriage, age of pregnancy, gestation sac size, if present, total dose of prostaglandin, and route of administration. It has a lower rate of pelvic inflammatory disease. Potential complication is increased pain and blood loss. It can be undertaken on outpatient basis. Recurrent miscarriage. This should be investigated by examining the karyotype of both parents and, if possible, any foetal product. Maternal blood should be examined for lupus anticoagulants and anticardiolipin antibodies on at least 2 occasions 6 weeks apart. If persisting positive, the client should be treated with low-dose aspirin and heparin in subsequent pregnancies. Those with karyotypic abnormalities should be referred to a clinical geneticist. An ultrasound scan to assess ovarian morphology for polycystic ovarian syndrome and the uterine cavity. Cervical cassage, carried out 14 to 16 weeks gestation in cases of cervical incompetence, reduces the incidence of preterm birth. Organization of care. There is need for early pregnancy assessment. Admission can be avoided. Direct access of client to healthcare giver should be made possible. Facilities for transvaginal ultrasound and rapid access to rhesus antibody screening and serum human chorionic gonadotropin estimation should be made available. The psychological aspects of miscarriage should be addressed, as to the medical personnel miscarriage is not regarded as anything serious, but to the clients, hunger, grief, and guilt are common, and in most women, distress for 6 weeks following miscarriage. Complications: pelvic inflammatory disease, uterine perforation, cervical trauma. Summary: at the end of the study session, you have learnt the definition of abortion, the different causes of miscarriage or abortion, the various types of abortion or miscarriage, its risk factors, the signs and symptoms associated with it, the diagnosis to detect miscarriage or abortion, the various management methods administered to miscarriage or abortion patients. End of study session 2. Thanks for listening.